Let's turn to atezolizumab, or MPDL3280A, another immune checkpoint inhibitor, this one against PD-L1, but a related target. And a very similar design. There was a trial presented by Dr. Spira and colleagues. And this was, again, immunotherapy compared with second-line Taxotere. Jean-Charles, what did you think of that presentation?
Well, Jack, that trial called Poplar was in fact indeed randomizing atezo versus standard dose of docetaxel second and third line. So it's a population that also embraces third line. And it was a pretty interesting trial because it had as a primary endpoint the evaluation of the survival benefit in the intention to treat population, but also as a co-primary in the PD-L1 defined positive population. And I think in that setting, the investigators at Genentech have done a much more refined work to figure out what was a biomarker. So instead of saying you are PD-L1 positive, whatever stains, mostly tumor cells, they have disentangled positivity in tumor cells, what they call TC for tumor cells, and positivity in immune cells that are present in your tumor. This is the sleeping army that you're supposed to wake up, and they call that IC. And what they demonstrate is that tumors who are TC3, IC3, so high tumor cell expression or high immune cell expression, do have the best benefit. In the overall population, the hazard ratio was 0.77. So let's say for the people who don't understand an hazard ratio, that you decrease the risk of progression by 23% in favor of atezo versus docetaxel. In the TC3, IC3 positive biomarker population, the hazard ratio was 0.46, meaning that you decrease the risk of progression by 54%. So you see there the power, as Lina has said, of a much more subtle and fine-tuned biomarker. And I think, it's quite eye-opening to see that it's not only being PD-L1 positive in the tumor cells, because you can be completely PD-L1 positive in tumor cells. If you have PD-L1 positive in the immune cells, then you're going to respond to. And this is a concept and notion that's not so clear there. So I think that was also very interesting data. The hazard ratios and the survivals medians have to be taken with caution because this is yet an immature trial, and median follow-up needs to increase so we have a full grasp of the level of benefit. But it's good news. And what is good news to me is that we have multiple players, and that's going to decrease the cost. Because Nivu is there alone, but Pembro is coming, Atezo is coming, and durvalumab, the AstraZeneca compound, MEDI4736, is also coming. So this is going to pull down the market.
Lina, what did you think of, first, the data with atezolizumab, or MPDL, compared with nivolumab? And again, this is a cross-trial comparison, so you can't take too much, but we already have one drug in the same setting, so it's hard not to compare. And then when we have nivolumab for everybody, do you think it would apply that the patients who are the highest stainers on, say, the atezo trials would be the very same great responders for Nivo? In other words, are there clinically significant differences among the immune checkpoint inhibitors?
Well, I completely agree with Jean-Charles that I think this was a much more scientifically rigorous study because it really took a much closer look at what's actually happening and what are the predictive markers beyond just PD-L1 on the tumor cells and how much of a role the immune infiltrate plays, because I think we really don't know a lot about what's truly happening. And even though everybody may get some benefit, clearly some are likely to get much better benefit than others. So I think that was a better trial for that reason. But how much of a difference it will make in the practical world is hard to anticipate right now, I think. I agree with Jean-Charles that I hope that the financial toxicity of all of these drugs will be less with more of them on the market. How different they are from each other is really hard to say. I think we've been involved in trials of all of these agents, all four of them, and we have not seen really significant differences either in activity or toxicity. Whether the immune infiltrate actually makes a difference in terms of predictive value over tumor cells is not clear, and whether that is actually only applicable to anti-PD-L1 drugs, which is what MPDL is. It's not an anti-PD-1 inhibitor. Is also not clear. From the pembrolizumab data that was presented at AACR and has been published, there was actually no difference in factoring in the immune infiltrate into their calculations of predictive value of PD-L1. Part of that issue comes down to lung cancer biopsies and what kind of material we'll get to actually look at. It's not easy to sample tissue from lung cancer patients, and we'll always get small amounts of tissue, so we have to be able to work with what we have, and I'm not sure how feasible it's going to be clinically to do this really rigorous evaluation of immune infiltrate.
One implication, though, of seemingly very comparable agents in the same class is that if there was a price advantage, that would be one real incentive when they are potentially kind of fungible choices. So we'll see where that evolves.